3. Good afternoon. I'm Dr. Wayne Scott, Chief of the Ophthalmology Service here at Kings County. I'm here with Dr. Leskov, and we're going to give a presentation on a brief introduction to ophthalmic surgery.
So I'm Ilya Leskov. I'm the chief of the retina service here at New York City Health Hospitals, Kings County. I want to start with a brief introduction to eye anatomy. The eye is roughly divided into an anterior and a posterior segment. To focus on the anterior segment first, we have the cornea, the anterior chamber of the eye right behind the cornea, the iris, and the central opening of the iris, the pupil, behind which lies the lens of the eye. The posterior segment consists of the vitreous that fills most of the eye, the retina, which is the main light-sensitive organ in the eye, and the choroid, which is an organ that supplies the retina with blood and other nutrients. All of the information that the eye collects, the visual information, gets transmitted to the brain via the optic nerve. And finally, the sclera is the white covering kind of forming the wall of the eye. The structural integrity of the eye is provided by the sclera. And Dr. Scott will talk about cataracts.
One of the major questions I get on a daily basis, Dr. Scott, what is a cataract? Cataract is a clouding of your natural lens that progresses slowly, where it affects your vision and the vision becomes very cloudy. Major risk factors of a cataract are aging process, significant medical problems such as diabetes, and certain medications such as steroids, and also UV exposure. What are the symptoms of a cataract? Clouded, blurred, dim vision, difficulty reading, worsening glasses prescription, light sensitivity, poor night vision, glares, and halos, and reduced color and contrast sensitivity, and also doubling of vision in one eye. What are the indications for cataract surgery? Increasing symptoms that affect your daily activities. On this particular photo, you can see in the patient's right eye that they have a very cloudy lens, and that's what a cataract is. What are the steps involved with cataract surgery? First, you're going to receive topical anesthetic. Corneal incisions will be made in the eye, and then with a special instrument, the intraocular lens is then broken up and removed with a phacoemulsification ultrasound machine. And then an artificial intraocular lens is placed inside the eye. And then the wounds are closed. Also, there are instruments and also equipment, for instance, laser assisted surgery, where the laser assists in the creation of the corneal incision, and the fragments are then broken up in the lens, and then the lens is removed. In terms of intraocular lenses, there are different types. We have regular, what we call monofocal lenses, which essentially only correct your distant vision, while multifocal lenses correct for your near, medium, and your distant vision. And we also correct for astigmatic issues with toric lenses. How long do cataract surgery last? Lasts for approximately 10 to 20 minutes. The post-op recovery time is 1 to 2 hours. Complications are very uncommon, but involve and include infection, inflammation, retained lens fragments, dislocation of intraocular lenses, hemorrhage, glaucoma, retinal detachment, and loss of vision. Some of the common questions. What happens to my vision after surgery? Most notice immediate vision improvement with further improvement as the eye heals. We ask you not to avoid or to avoid strenuous activities for a few weeks, and no driving for at least 24 hours after surgery. Usually your surgeon will determine when it's okay for you to drive, and most patients are okay to fly or travel within several days. The new artificial lens that you receive lasts a lifetime without clouding. Occasionally, after the procedure, there's some clouding of the membrane, which is posterior to the lens, which requires a single in-office laser cleaning.
So I'll then talk about retinal detachment, which is one of the most common problems encountered in the retina clinic. So again, the eye is filled with a thick, sticky substance called the vitreous. It's about the consistency of egg whites, so it's sticky but transparent. And the retina is lining the posterior surface of the eye. And the retina can detach, as shown here. There's the detached retina, and there's a tear or hole in it. So retinal detachment is a sight-threatening and occasionally blinding condition. It will blind a patient if it's not corrected promptly. The incidence of retinal detachment is about 1 in 10,000. And the risk factors are age. Most patients who suffer from retinal detachment are in the range of 40 to 80 years old. Most are male. Most have myopia or nearsightedness. Frequently, patients have peripheral retinal degeneration or areas of retinal weakening. And occasionally we see patients who have a recent history of trauma. So the pathophysiology of retinal detachment, the first step is the liquefaction of the vitreous body, and that happens with age and sometimes with trauma. When there's traction on the retina by the vitreous, the retina may tear, and then the fluid that's in the eye may enter the subretinal space through the tear, resulting in a separation of the retina from the underlying tissues. So here's a photograph of a retinal tear. You see that in the upper left. And this is another photograph, and you can see a very similar tear looking a little bit like a triangle there, with the retina around it being detached from the posterior part of the eye. Here's a larger area of detachment in this patient, and the tear is actually enormous. It encompasses the entire left side of that photograph, right in front of the detached retina. So the symptoms of retinal detachment are sudden and painless decrease in vision. Sometimes patients report that this is like a visual obscuration that's like a curtain obscuring their vision. This may be complete or just be in one part of their visual field. And it's often preceded by patients experiencing new floaters or flashes of light. On exam, we see the detached retina, which has this very characteristic appearance that you saw in the prior photographs. Sometimes this is accompanied by hemorrhage and visible tears in the retina. And the treatment, as I mentioned, is surgery. And this is an urgent surgery. In some cases, the retinal detachment needs to be repaired within a day or 24 hours of diagnosis. In other cases, we can delay for up to 7 days after initial presentation. So the principles of retinal detachment repair are: we need to find all the breaks. We need to irritate the retinal and subretinal tissues around each break. We do this with cryotherapy or laser therapy. And then we bring the retina and the irritated underlying tissue into prolonged contact, and that results in a lasting adhesion between the retina and the underlying tissue. We can do this bringing together via 2 procedures. One is called scleral buckling, and the other is called a vitrectomy, and I'll go through both of those very quickly. So here's another diagram of a detached retina with a tear, and you can see the vitreous there as well. And we're going to be focusing on this little area of the eye. Here's a schematic. Here's a retinal detachment. So as you see the sclera, which is, and the choroid, these are the tissues underlying the retina. The retina here is in yellow-orange, and there's a break in it, which I'm labeled as the tear. There's SRF, which is subretinal fluid. This should not be there. The retina is detached from the tissues that usually underlie it directly, namely the choroid and the RPE, the retinal pigmented epithelium. So the vitreous places some traction on the retina, and that results in fluid going through the tear into the subretinal space and resulting in subretinal fluid. In scleral buckling, what we do is we bring a cryotherapy probe and we freeze a part of the sclera, the choroid, and the retina, resulting in irritation of those tissues. And then we put a silicone element, which we call the scleral buckle. It buckles the wall of the eye, the sclera, and brings the sclera, the choroid, and the RPE close to the retina. And because there's prior irritation from the cryotherapy, this creates a lasting bond between the sclera and the retina. So here's an example of an eye that has undergone scleral buckling. This buckle element is usually made of silicone these days, and you can see how it's indenting the eye. The buckle can be sectoral, very small, or it can be circumferential, a much larger element. And they can be thin, as in the middle picture, or they can be much wider, as in the lower picture. Scleral buckling is a relatively older procedure. It was pioneered in the 1950s. It pretty much has remained unchanged since that time, though the material from which the buckle is made is now silicone as opposed to other substances that they had been using before. And it's relatively less invasive in the sense that we don't go into the eye, we operate around the eye and on the eye surface. Vitrectomy is the other procedure that we use for repair of retinal detachment. This is the same schematic that you were seeing before. In vitrectomy, we remove the vitreous from the eye and we drain the subretinal fluid. The process of draining reattaches the retina, and in order to hold the retina in its correct place, we will be using some gas. But when we reattach the retina, we need to, again, irritate the tissues around the break. This we do with laser, and then we put some gas, into the eye to hold the retina in place against the choroid on the RPE while it heals in place. Eventually, the body will reabsorb the gas. So vitrectomy is actually very similar to laparoscopy. As you see here, we put 3 ports into the eye. We have an infusion line, which is similar to an insufflation tubing in a laparoscopy. And we have some instruments that we put through the side ports. The instruments include a vitrector, also called the cutter. This is the main instrument with which we use to remove the vitreous from the eye. It works like a little guillotine, so small parts of the vitreous are sucked into the tip and then they're chopped off. And these come in different gauges, just like the different ports that we use. We also need to see what it is that we're doing in the eye, and this is what we use, the so-called light pipe or an illuminator probe through the other port. Some of these incorporate laser, which we use, as I mentioned, to irritate the tissues around the breaks in order for the breaks to close permanently. Other instruments that we use include microforceps and scissors, which are shown here, various kinds of microforceps. We use cautery in the eye if there's poorly controlled hemorrhage, and we have snares to pick any objects up in the eye and for other purposes. The vitrectomy is more invasive than scleral buckling in the sense that the instruments go into the eye, but ultimately in the postoperative recovery, this is less painful and less uncomfortable for the patient than scleral buckling. Vitrectomy has undergone improvements over the years. We've moved to smaller gauge instruments that allow us to close the wounds in a sutureless manner. We have achieved better fluidics control during surgery. We have more and better instruments. The duration of vitrectomy is about 1 to 3 hours, depending on how complicated the case may be. But regardless, this is usually day surgery and patients get to go home at the end of the day. The recovery from vitrectomy is about 1 to 2 weeks, and there's face down positioning. The reason for this is that the gas bubble that I mentioned that's in the eye needs to press on the retina. The retina, as I had mentioned, is in the back part of the eye, and so we need to have the patient rotate their head and their eye in such a way that the gas bubble, which rises up, will also press and tamponade the retina, and so this requires face down positioning. The success rate for vitrectomy is over 95% with single surgery, resulting in a reattachment of the retina and improvement in vision. And just a general overview of what eye surgery looks like, these are some of our trainees here. We usually operate in a dark environment to minimize distractions for the surgeon in their peripheral vision. We have a 2-headed microscope, one for the surgeon and one for his or her assistant. The eye is somewhere there under the hands of the surgeon. The surgeon is seated and the hands of the surgeon are braced to minimize any micro movements of the surgeon. The surgeon has fine instrument control with their hands, and that's why the hands are braced. But if you notice, the surgeon's feet are placed on pedals. Both feet are on 2 pedals. And the pedals are used to control the operating microscope and to control the instruments in a gross manner, the speed of any electrically controlled movements, etc., and also the fluidics in the eye. So as you see, we have to develop very good core strength to control the instruments both with our hands and with our feet. It's a little bit like playing an organ in the church. Thank you very much. We'll take any questions. So again, I'm Ilya Leskov. I'm the chief of the retina division in the Department of Ophthalmology at New York City Health and Hospital Systems at Kings County.
I'm Dr. Wayne Scott.